Doc, I've got gout. Welcome to Introduction to Rheumatology. Today we will be discussing gout. Typically that's discussed with another crystal-induced arthritis condition called pseudo-gout or calcium pyrophosphate deposition disease, but I will put that in a separate lecture.
So gout is a type of inflammatory arthritis that's triggered by crystallization of uric acid in the joint. It can be associated with increased blood levels of uric acid. It can also be associated with formation of tumor-like growth of uric acid crystals called Tofi. So this is different than the other inflammatory arthritis conditions we've discussed so far, such as rheumatoid arthritis and psoriatic arthritis and the seronegative spondyloarthropathies. It's not autoimmune mediated, rather it's due to an irritating substance in the joint causing the inflammation. So what causes gout? Quite simply, it's due to an excess of uric acid or urate in the body. Humans as a species, and compared to other animals, have a defect in this uricase enzyme, which synthesizes uric acid to a less or more metabolizable form. In other words, it gets rid of the uric acid. Humans lack that enzyme, and so our uric acid is 10 times that of other animals' species. Because of that, the levels of uric acid in our blood are, even in normal people, are approaching uric acid saturation. Now, there's certain factors that can then push one over the edge so that the uric acid does saturate and crystallize in the joints. Number one is things that increase the uric acid production. Dietary purines, specifically meats and seafood, can increase uric acid levels. But interestingly, foods that are high in purines, such as oatmeal, peas, lentils, etc., don't seem to increase the serum uric acid levels. The vast majority of patients have problem with increased salvage purines that from increased cell turnover. One exogenous cause of this is increased cell turnover in patients that have destruction of the red blood cells, such as a hemolytic anemia, or destruction of other cells, such as chemotherapy for cancers. Only a small portion of patients have inborn errors of metabolism, but that can be another potential cause. Alcohol can increase the endogenous purine synthesis, and it does this by increasing the net ATP to AMP degradation. Interestingly, beer seemed to do this more than other alcohols, and wine had no increased risk. Fructose metabolism also can increase uric acid, and of course this has been associated with high sugar beverages. Patients that have insulin resistance syndrome and obesity have an increased risk of gout. And then just having increased fat, adiposity, can be associated with increased insulin resistance and gout also. So we talked about things that can potentially increase uric acid. Decreasing the ability of the body to get rid of uric acid can also increase the net amount of uric acid in the body. Things that decrease renal excretion and lead to uric acid accumulation include hypertension. Urate excretion is low in essential hypertension compared to the glomerular filtration rates. Some of the medicines that we use to treat hypertension can decrease excretion. In particular, hydrochlorothiazide does this. Diabetic ketoacidosis and alcohol intoxication can also increase urate retention. So we saw two ways that alcohol can increase the urate. One is by the increased metabolism of ATP, and the other is by decreased excretion in the kidney. Certain medicines and pills we take, such as niacin and pyrazinamide, which is a treatment of TB, can also increase or decrease the excretion of uric acid. Low levels of salicylates or aspirin can inhibit uric acid excretion, but interestingly, very high levels of salicylates can increase uric acid excretion. So we find that patients that have low levels, taking low levels of aspirin, can increase their risk of gout. But when we used to use aspirin to treat rheumatoid arthritis, we would give very high levels of aspirin, and one way that we would determine if the patients were taking the medicine is look at the serum uric acid, and we found that it was often very low in those patients on the really high levels of aspirin. Pathologically, what we see is there's a very inflamed synovial fluid, and if you look at this right stain, you see many polymorphonuclear white cells in the stain. With polarized light microscopy, monosodium urate crystals are seen, and these are these needle-like crystals that are seen in the joint. Frequently they're seen poking through the white blood cells. And as you can imagine, these are very irritating and they cause more inflammation. Patients with gout can have such large collections of uric acid that they form nodules, shown here. We call these Tofi. Basically, these are just uric acid. If one were to puncture this and squeeze it, the material that would be expressed would be a creamy white substance that I liken to the old white Colgate toothpaste. If we look at it under the polarized microscope, we see these sheets of uric acid crystals, which are actually very pretty. They almost look like a geothermal map. And you'll see they're sort of yellow in the plane, the polarizer, and they're blue perpendicular to it. So you see these sheets of uric acid crystals. So how does the uric acid lead to gout? Well, the crystals in acute gout, they're marked to be eaten or opsonized, and then they are eaten or phagocyzed. These then stimulate the white blood cell to release its enzymes and can cause a lot of damage in the area. There's also a large influx of neutrophils because of this. And sometimes the uric acid crystals can also interact directly with cell membranes and cause irritation. In chronic gout, this can even lead to a chronic synovitis and cartilage loss, somewhat like rheumatoid arthritis. What do we see clinically? Number one, the prevalence of this is pretty high. About 3.9% adults in the United States have it. And classically, what is described is a monoarticular, generally just one joint involved, very inflamed and very painful joint of acute onset. The most common joints involved are the first metatarsal phalangeal joint. That's the one classically seen, but it can involve the metatarsals, it can involve the knees, it can even sometimes involve the upper extremities like the fingers. Patients will typically describe the onset coming on within just a few hours, and a lot of times they can almost tell you to the hour the start of the pain and the swelling of the joint. The pain is severe, and I liken it to one of the three great pains, the three great pains being gout, kidney stones, and childbirth. It's a very horrible pain, and the patients wake up with this. Most often with the first flare, it is the lower extremity, and we talked about the joints that are most typically involved. The signs of inflammation may extend beyond the joint, and it can look like a cellulitis. We'll talk about that when we get to the differential. Generally, it's not polyarticular with the first flare. Usually the first flare has polyarticular involvement in less than 20% of the cases, but as time moves forward, patients can have more joints involved with each flare. The times between flares the patients can be completely normal, no joint pain or anything at that time. However, in spite of this, the metaphaseous material may be depositing in the joint and causing damage. So it is important even to recognize it in patients that are having more flares. And then the collections of the solic uric acid can be accompanied by chronic inflammation and often destructive changes in the surrounding connective tissue. So again, what do we see on physical examination? A warm, hot, swollen joint. And if you were to lay your hand on that toe or on that forefoot, one would feel heat. When it involves the first metatarsal phalangeal joint, we call it podagra. These are just examples of the gout collections or tophi. And it's important to look for these in somebody that presents with an inflammatory arthritis, especially monoarticular, one would probably recognize this on the elbow with the Tofi material being expressed on the finger, but sometimes one has to look for them on the ears. And so it's very important to do a careful examination in somebody with an inflammatory monoarthritis looking for Tofi. Again, if one were to express or enroof this tophaceous material, it's sort of a white Colgate toothpaste type of material. The main special study which is done to make the diagnosis of gout is joint aspiration. And if one has a joint that one could get fluid out, it's imperative to get that fluid out. The fluid that's obtained is typically inflamed, and the reason I can tell this fluid is inflamed is it's very cloudy, and that's due to the white blood cells in the fluid. The synovial fluid is examined, and an important part of that examination is to look at the fluid with a polarized light microscope. I'll talk about that more when we talk about joint aspiration, but looking under a polarized light microscope, the crystals, the gout crystals, the uric acid crystals just pop out. They're very easy to see. Classically, to make the diagnosis, I look for a crystal that is intracellularly and typically poking through the cell. To me, it looks like the classic null sign of math. The crystals, when lined up with the plane of the polarizer, are yellow, and when perpendicular, they're blue. We have a little saying we use to remember this: allopurinol, or yellow parallel, allopurinol being one of the medicines that we use to treat gout. Other tests that are done, typically the sedimentation rate is high and the C-reactive protein is high, showing that there's inflammation. There can be leukocytosis on the blood count. The serum uric acid frequently is high, but is not always high. So I wouldn't use that as a way to make the diagnosis of gout. A patient that has a monoarthritis with a high uric acid, I don't think is sufficient data to make the diagnosis, nor is the fact that a patient has a normal uric acid and a monoarthritis rule out gout. With respect to imaging in patients that have had long-going disease, they can get cysts, and you can see this, what we call a rat bite erosion. There's a cyst in here. This is probably a tophus if one were to stick a needle in it, and you can see the sort of the edges of the bone surrounding. These are called rat bite erosions. More recent imaging studies that have been shown to be helpful in making the diagnosis include the MRI, ultrasound, or dual energy CT. What things look like gout? And this gets back to our differential diagnosis of an acute inflammatory arthritis. Probably the most worrisome thing that looks like gout is septic arthritis. So again, that makes it very important to drain the joint to see if fluid can be obtained, not just to look for crystals, but to be sent for cultures. Calcium pyrophosphate deposition disease, CPPD, or pseudogout, can have an onset very similar to gout, with a sudden onset and pain and swelling in the joint, although the distribution is a little bit different. It tends not so much to affect the first metatarsal phalangeal joint. It can affect the ankle and knee, and more often affects the wrist than we see in gout. Autoimmune arthritis can sometimes present with a monoarticular presentation, in particular the seronegative spondyloarthropathies we talked about, but also rheumatoid arthritis can. So what helps us to make the diagnosis? And this is what we call classification criteria. As I've noted before, classification criteria are a set of criteria used so that everyone can agree somebody has a diagnosis that's in a clinical study. It's for study purposes. So I don't call these diagnostic criteria, but I think in understanding them is helpful because it helps one understand when one goes to make the diagnosis. These are the 1977 criteria. There's a more recent set of criteria which I'll discuss in a minute, but I find the 1977 criteria most helpful because, at least at the bedside, because basically one just looks for these 12 things, and if they have 6 of the 12 things, that at least leads one to classify them as gout. And just sort of going through this: rapid onset, maximum inflammation in 1 day, more than one attack, although obviously this has to start somewhere. If they have a monoarticular arthritis, if there's redness over the joint, if they have first metatarsal phalangeal joint or podagra. If it's just on one side in particular, that counts as a factor. If they have a unilateral tarsal attack, that can count as a factor. If one finds a tophus, that basically helps. If they have increased uric acid in the blood, the swelling's asymmetric. If one sees cysts or erosions on x-ray, and if the fluid is cultured and there's no infection, these are all important factors. Again, if one finds 6 of them, that's helpful to classify, again, for the purposes of study, but it can be also helpful at the bedside in making the diagnosis. From my perspective, the sine qua non for gout is the presence of uric acid crystals on synovial aspiration. So really the most important criteria is to drain the joint, look for crystals. Now, as I mentioned, there is a newer criteria for classification. This is the 2015 American College of Rheumatology proposed criteria. It does have better operating characteristics than the old criteria and includes imaging other than just X-ray. It also includes the use of MRI, etc. The trouble with it is it's a weighted scoring system. In other words, each criteria you add up a different number of points. It's helpful to put people into studies, but I don't find it so helpful in the office when I'm seeing patients. They do have a web-based calculator available. I have included a reference to the paper discussing this classification on my list of references, and you'll see that listed below. Now, the treatment of gout. Actually, I consider gout very easy to treat. However, I find a lot of people don't understand this, and by people I mean physicians. And because of that, I've had a lot of patients referred to me by physicians, whereas I think really this disease could be managed by a primary care physician. When the patient presents with acute flare, this should be addressed as soon as possible after onset. And then once the acute flare is under control, then one can think about long-term treatment. So for an acute attack, typically the medicines we use are either the nonsteroidal anti-inflammatory drugs or corticosteroids or colchicine. All of these work, and really the biggest problem with any of them is their potential side effects. Nonsteroidals can be helpful, but in patients that have stomach problems or renal insufficiency, one really doesn't like to expose them to that. I personally really like colchicine more for chronic prophylaxis than acute flares. With respect to acute flares, the current recommended treatment is taking 2 colchicine at the onset and then 1 an hour later. The old treatment that we used to do was to have patients take 1 colchicine every hour until they had control of the flare or diarrhea. And the patients could get severe rip-roaring diarrhea with this, so it was a very, in a way, cruel treatment in that you gave patients that had a painful joint a reason to have to go to the bathroom a lot. Corticosteroids, either as a pill, systemic, or as a shot into the joint, can shut the flares down very quickly. And more recently, there's discussion and there's some papers to support it, although not approved by the FDA, and the use of IL-1 inhibitors. IL-1 inhibitors includes things like anakinra or Kineret or canakinumab or Ilaris. This is not on their package insert, but they can be of help. In patients that just have 1 attack, typically you treat the acute attack, let it pass, and wait and see if they have more attacks. If they never have another attack, one doesn't need to treat. However, if they start having more than 1 or 2 attacks a year, it's important to try to prophylax the inflammation and eventually lower the uric acid. So the medicines that we use for the prophylaxis again include colchicine, the nonsteroidal anti-inflammatory drugs, or prednisone. Personally, for this purpose, I really do like colchicine. I think it's a useful drug. It can be used once or twice a day. The problem with it is that it's currently very expensive, and I'll talk about that when I get down to problems I've had with insurance covering this medicine. It does have potential side effects in that if there's renal insufficiency, there's an increased risk of bone marrow toxicity with it. It can sometimes affect the muscles, but I think using judiciously in a low dose, monitoring carefully, it's actually easier to use than nonsteroidals. Nonsteroidals can be a problem because they can affect the stomach, they can affect kidney function, they can affect the blood pressure. Likewise, I think it's easier to use than prednisone. Prednisone with its side effects, weight gain, osteoporosis, the thinning of the bone, it's glucose intolerance, etc. But having said that, any of these medicines can be used for prophylaxis. Patients that are having more than 1 to 2 flares a year, then it's important to prophylax against inflammation. And I want to have the attack cool down and the patient on prophylaxis before I consider uric acid lowering. With respect to lowering the uric acid, it's important to consider lifestyle and diet changes, although typically my impression is that's not sufficient if they're having more than 1 to 2 flares a year and one needs to proceed to chronic anti-inflammatory prophylaxis in the consideration of a medicine to lower the uric acid. However, I think it's important to let patients know that organ meats, high fructose corn syrup, alcohol can all increase the uric acid production and retention and increase the risk of gout. Any non-essential medicines which can cause hyperuricemia, such as thiazide diuretics, need to be avoided if possible. And again, that if one can't control the blood pressure without the use of thiazide diuretics, those need to be used, but if they can, it's important to avoid. Now, with respect to uric acid lowering medicines, I don't like to start these until the acute flares are controlled. And typically I won't. I've found oftentimes if the patient started on a uric acid lowering medicine during a flare, it will make the flare worse, and that's been a source of referral. Now, if one looks at the most recent American College of Rheumatology guidelines, they actually conditionally recommend starting the uric acid lowering even in the face of a flare, provided the patient's on anti-inflammatory prophylaxis. Indications for lowering uric acid include, again, more than 1 to 2 attacks per year, especially if there's a Tofi, chronic kidney disease, if there's a history of kidney stones. But uric acid lowering is not recommended in patients that just have asymptomatic hyperuricemia. In other words, uric acid elevations noted on lab, but the patients have never had a flare of gout. Typically, a xanthine oxidase inhibitor is used first, and typically that's allopurinol because of cost and safety. Now, there is a potential risk of allopurinol in that it can cause a fatal Stevens-Johnson syndrome. This is of higher risk in patients that are from Southeast Asia or African American descent. And this group of patients, it's recommended that an HLA B5801 be checked prior to the initiation or consideration of xanthine oxidase inhibitors. Patients with chronic kidney disease, allopurinol may be used and even titrated to a sufficient dose, which is a little different than what some of my renal colleagues will tell me or do. I've actually had some of my renal colleagues decrease the dose of a xanthine oxidase inhibitor such as uric acid when they find chronic renal insufficiency. But the fact is, this medicine has been shown to be helpful and it's shown to be safe to use. It's just one needs to start in a much lower dose and try to titrate up much slower in patients that have chronic kidney disease. And again, I put the reference to that paper in my reference list. So typically I'll start allopurinol at a dose of 50 to 100 milligrams per day, and then I'll increase it slowly over every week or two until I get up to at least 300 milligrams per day. I'll watch the uric acid level at that dose. If after a couple of months they're not to my target, I'll increase the dose further, and I'll go as high as 600 milligrams of allopurinol per day, and I've seen papers suggesting 800 milligrams. Typically, I do treat to target, and what I'm trying to achieve is a uric acid less than 6 milligrams per deciliter, and hopefully close to 5 milligrams per deciliter. Now, the problem with treatment with allopurinol or any of the medicines is once you started it, it's a lifetime therapy. These are not intended to be treated to get the uric acid level down and then go off of it. It is a lifetime therapy. Febuxostat I'll use in patients that do not tolerate allopurinol. However, on the box there is a black box warning against cardiovascular disease. In other words, there seems to be an increased risk of coronary artery events such as heart attacks and strokes in patients on the febuxostat. However, there's also an increased risk from the elevated uric acid. So the medicine's used, but it has to be used carefully. The current American College of Rheumatology guidelines favor taking febuxostat even if there is a history of coronary vascular disease. Now, with respect to uricosurics, these are medicines that actually increase the excretion of uric acid from the kidney. We used to measure the urinary excretion of uric acid by getting a 24-hour urine, and if it was greater than 700 milligrams per day, we would not use it, but if it was less, we might try that as our first choice. Now we just go to the xanthine oxidase inhibitors. The uricosuric medicines, again, probenecid in particular, probably don't have any benefit if the creatinine clearance is less than 50 milliliters per minute. Or if there's a history of kidney stone, you don't want to use it because obviously you don't want to put more uric acid into the urine. But it is used in patients that seem to be somewhat refractory to treatment with the xanthine oxidase inhibitors as a concomitant therapy. In other words, I'll push the xanthine oxidase inhibitor up to its maximum dose. If I still haven't achieved my target uric acid, serum uric acid, then I will consider the addition of a uricosuric. Interestingly, as I mentioned, high-dose aspirin can be used, and I tried this on one occasion in a person that I wasn't getting anywhere in their treatment. Didn't work so great. There was another medicine called lesinurad or Zorampic, which was a uricosuric, which is on the market briefly in the United States, but has since been taken off the market. Now, pegloticase, which is pegylated uricase, is not a molecule that humans have, and by pegylating a molecule, you can get it into the body without an immune response. This has been used to treat and get rid of uric acid in the body. And it sounds like that it can be very effective. Basically, it removes uric acid when xanthine oxidase inhibitors have failed. There is a black box warning of anaphylaxis and infusion reactions. And quite frankly, in my practice, I've not had any success using this medicine. I've only had a few patients where I couldn't achieve my target uric acids with the methods that I discussed above. I had one patient that I did use it in. He did not tolerate it at all. He was in heart failure, and we had to withdraw it, and he ultimately died not soon after stopping the medicine. I've had other patients that I wanted to use it in, but their insurance company would not pay for it. So I've not had a lot of its success. I will say that I do have problems with insurance companies and gout treatments. I mentioned how colchicine is used to suppress the flares of gout. This medicine has actually been around for centuries and centuries, and prior to the year 2010, the drug was only priced at about 10 cents a pill. However, as part of the FDA's program for what they called the Unapproved Drugs Initiative in September of 2010, the FDA ordered that to halt the manufacture and distribution and marketing of all unapproved single ingredient colchicine. And so there was one company that did take the colchicine through the clinical trials as the FDA required, and they now market it as Colchris, and the medicine went up from $5 or from 10 cents a pill up to $5 a pill. So as you think about it, I had a medicine that if I were giving twice a day, the cost would be 20 cents times $6 a month. now the medicine costs $300 a month, so it's very expensive. So when I've gone to prescribe this medicine as a inflammatory prophylaxis while I'm starting the uric or the xanthine oxidase inhibitor, I've got notes from insurance company benefit managers saying, well, they're not going to pay for colchicine, use an alternative therapy for gout such as allopurinol. You can see that allopurinol is not equivalent to colchicine in the treatment of gout. Colchicine suppresses the inflammation, which you need to do prior to starting the xanthine oxidase inhibitor, because if you lower the uric acid without the presence of an anti-inflammatory, one will get a flare of gout. So it really is a conundrum, and it really causes an irritation in the practice of medicine that these pharmacy benefit managers don't understand the treatment of gout. And then lastly, as I noted before, asymptomatic hyperuricemia is not treated. One last concept I would like to discuss under treatment, and that's the concept of the pill in the pocket. Patients who are on anti-inflammatory suppression while their uric acid lowering drug is being titrated, or even patients that are on a uric acid lowering drug only after they have had their uric acid controlled for a while, are at risk for flares of gout. Rather than requiring the patient to call the office for medication or to come into the office to be seen to initiate medicine, we like to give the patients what we call a pill in the pocket. And basically this is an anti-inflammatory to use if there's a breakthrough flare. If the patient's already on an anti-inflammatory drug such as colchicine, one might use prednisone or a non-steroidal anti-inflammatory drug. A script is given for a small supply of this. The patient is to purchase that and keep it available, so if they do get a flare, they can start the medicine and hopefully abort the flare. I've had patients that have found that just even with a little hint of pain in a toe, they can take 1 or 2 doses of a medicine such as prednisone or a non-steroidal anti-inflammatory drug and abort the flare. So what things do we follow in patients that have gout? Number 1, renal complications of hyperuricemia and uric acid crystal deposition need to be watched for. The patients are at risk for kidney stones. They can either have uric acid stones or calcium oxalate stones. They're at risk for chronic urate nephropathy. And this is common in gout and reflects the coexistence of high blood pressure and diabetes and obesity and atherosclerosis, and in rare cases, at least in the United States, lead intoxication. Urate crystals can be deposited in the renal medullary interstitium, producing a chronic inflammatory reaction, fibrosis. So that's a potential bad side effect of gout. With respect to following it, other things that I watch for depends on the medicines that they're used. So if they're on allopurinol, I'm watching and monitoring that, or colchicine, we talked about the potential risks and challenges of that. Again, when I treat, I'm treating to target. My goal is to get the uric acid to less than 6 milligrams per deciliter or better, and so I am following the uric acid serially. And then lastly, we talked about even if we have reached our target, even if the Tofi have resolved, we can't stop treatment. Really, treatment for gout, at least uric acid lowering, is lifelong. Now, colchicine or non-steroidal anti-inflammatory drugs or whatever one's using to suppress the flares, those can go away, and eventually we get patients on just allopurinol alone, but we generally cannot stop the medicine that we're using to lower the uric acid. So in conclusion, gout is a disease that actually is generally pretty easily treated, and I think a condition that can be managed by a primary care physician. It is important when a hot, swollen joint presents to the physician to drain the joint to confirm the diagnosis. It is very easy to diagnose gout with synovial fluid, as uric acids are seen on polarized light microscopy. With the acute flare, the flare needs to be treated, and this is done with anti-inflammatory drugs such as colchicine, corticosteroids such as prednisone, or non-steroidal anti-inflammatory drugs. I do not initiate uric acid lowering during a flare, as it can make the flare worse. After the flare is under control, it's important to initiate a treatment to suppress future flares. And again, we use the same medicines, colchicine, corticosteroids, or nonsteroidal anti-inflammatory drugs. After initiation of inflammation suppression, then uric acid lowering can be started. Typically, I start in a low dose and gradually build the dose, in particular with respect to allopurinol, in order to avoid flares of the gout and also avoid reactions to the medicine. The patient should be treated to target, or treat to target, and that means we're trying to drive the uric acid to a level less than 6 milligrams per deciliter and preferably close to 5 milligrams per deciliter. And lastly, I give the patients a prescription for a pill in the pocket, which is an anti-inflammatory medicine to use, again, colchicine, prednisone, or nonsteroidal, so that they can put out the flares on their own if they get a flare between office visits and not require them to call the office or come in to see the physician. This completes my discussion of gout. I plan on working on calcium pyrophosphate deposition next. Thank you for listening, and we'll see you later. Bye.
Thank you for listening to my lecture today on gout. Please be sure to check out my other lectures on the Introduction to Rheumatology channel.